We know there's a great need for major markets in the San Francisco Bay Area, San Jose.
and good afternoon. My name is John Packham. It's my pleasure to share some information pulled together by my office on health and healthcare in rural and frontier areas of the state. I've got quite a bit of data that I'm going to go through and welcome questions, and feel free to interrupt me anytime if you think I'm motoring through this too quickly. I'm with the Nevada State Office of Rural Health, which is an office within the Office of Statewide Initiatives. We're based at the School of Medicine here in Reno, and we oversee a wide range of health and health professions, programs, outreach, technical assistance, and so forth. I'm funded in part through a grant managed by our office called the Nevada Flex program. It's a HRSA-supported program. So with no further ado, I will go into this presentation. Troy has told me that it will be available online. And if you have any questions about the material that you don't bring up today, feel free to contact me anytime, and I'll be providing my contact information at the end of this presentation. Are you ready?
Go ahead.
Okay. The information that I'm going to be sharing with you this afternoon is drawn from the Nevada Rural and Frontier Health Data Book. This is a volume that's put out by our office every 2 years. We time it in advance of the legislative session with the intent of making sure that, among other things, this information gets in the hands of policymakers. We believe it's the most comprehensive source of county-level data on health and healthcare. There's plenty of county-level data out there, and much of it is good, including data that you'll find on the Health Division website. What we've tried to do is package it in a single volume, again, for use not only by state policymakers, but also many of the folks that are on this educational offering today, in the sense that if you're writing a grant, if you're doing local health or healthcare planning, we hope that you find this information of value. And again, as I will close this presentation, encourage you to contact us anytime if you would like additional information or data. Thought I'd begin with some information, kind of kick this off on a slightly lighter note and a more descriptive note by sharing a couple of maps with you that I put together for a presentation that I originally made in Duluth, Minnesota, but that I'll be making in Utah in a couple of weeks, really just to highlight some of the unique aspects of health and healthcare in Nevada. The first map is, and again, all of these maps are contained in the data book. The resolution might not show up great on video, but go to that data book, and I'll give you links and so forth to that. A couple of interesting features of the distribution of population and resources in this state is the largely frontier area and geography of the state, despite the fact that we are considered to be a very urbanized state. And another way of saying that is that 90% of our state's population resides in counties that only comprise 13% of our state's landmass. By contrast, rural and frontier counties, that is the 14 lightly shaded and blue and darker blue counties on that map, are ones that comprise over 85% of our land mass, yet only represent a little under 10% of our state's population. Second map I wanted to share with you is one that really, much more than the preceding, highlights the variation in rural versus urban parts of the state. thinking back to the previous election, and I've got my color scheme completely backwards. The urban counties and areas of the state are the darker red, whereas the more rural and frontier areas are blue and shades of blue here. And a couple of things I'd like you to think about when you look at this map is urban areas of the state are very densely populated, the dark red on that map. And that stands in contrast again to the enormous amount of rural and frontier regions of the state, if not unpopulated areas. The areas shaded in gray are largely unpopulated areas. The map also highlights, for those of you familiar with Nevada, those parts of Clark County down in the south and Washoe County up north, that while being urban counties, nonetheless contain unpopulated as well as distinctly rural and frontier areas. For those of you familiar with the Critical Access Hospital Program, for example, Washoe and Clark contain 3 critical access hospitals that meet our state's definition of rural as well as federal criteria for those programs. Now I want to talk a little bit about maps that highlight distance and the unique geography of our state. This is a photo I snapped right outside of Battle Mountain Hospital on my way back to Reno. Interestingly enough, one of the features of health and healthcare in our state are again, enormous distances that not only separate rural towns from one another, but those same hospitals and facilities from tertiary care and even technical assistance. A couple of years ago, I was writing a grant and was approached by the agency that I was applying to, wondering why I requested so many dollars for travel. And I said, well, the average distance between my office and the hospitals I work with is over 250 miles. And they took a more sympathetic ear, but I think it's important just to highlight the degree to which not only rural communities in this state are separated from tertiary care and services only available in Reno, Las Vegas, Salt Lake, and so forth, but also from technical assistance and other resources provided. Continuing that discussion of the unique terrain, there are very few straight lines in the topography or highways and so forth in Nevada. And again, another item, another map contained in the data book, including the loneliest highway in America that I will be on my next trip out to Ely. Travel time in this state, unlike other areas that I've lived in my life and career, measured in hours, not minutes. Here's a funny little haha. This was actually a picture I snapped outside of a couple of blocks from the hospital in Ely a couple of years ago. A little slightly dated, but leads to my final set of maps, and that has to do with another incredibly unique feature of Nevada, and that is the degree to which most of those rural and frontier areas that I spoke of in the previous maps are owned by state and federal governments, particularly the federal government. That kind of lightly shaded yellow or salmon color is BLM land, and the wine-colored red and darker areas are Department of Defense and Energy, with variation in public lands, again, owned and managed by a variety of federal agencies. The private land or private areas of that map are the black areas, and again, they stand out just by the degree to which they are a minority of the landmass. Final map, and one I always like to share when I'm trying to describe how big Nevada is compared to other states in the country is one that we've put together that puts 7 New England mid-Atlantic states within our boundaries. I recently read a grant proposal on a grant review, and the applicant was just, trying to describe how widely separated the hospitals, the 14 rural hospitals, were in New Hampshire. And I was thinking the whole time that that state of New Hampshire could almost be fit into White Pine County, or one of our larger counties in Nevada. Okay, so that's a little quick tour through some of the maps contained in the data book. I wanted to begin my discussion by going over some of the healthcare challenges that the data I'm going to share with you point to, and that have been kind of revealed, if you will, in various iterations of the data book and community needs assessments undertaken by the Nevada Office of Rural Health. These challenges, again, that I will illustrate in depth today include access to essential healthcare services. Those access barriers are a function of health insurance, of course, and cost barriers that are unique to rural parts of the state. For example, private plans available on the health exchange. Rural residents are typically don't have the plan availability that you see in urban areas of the state or other parts of the country. Another interesting development with the Affordable Care Act has been improvement in those uninsured rates, but a distinct growing proportion of patients with public health insurance coverage, particularly Medicaid and Medicare. I'm also going to share with you some information that highlight comparatively higher levels of chronic disease and some of the risk factors that are associated with chronic disease, and again, how those vary in rural versus urban parts of the state. Rounding out the list of challenges that will be highlighted again in the data I'm about to present are varying threats to the economic viability of healthcare providers in rural areas, including hospitals and clinics, but as well as other services that are either in short supply or non-existent in those areas. But one of the chief aims of the programs overseen by the Nevada Office of Rural Health are to assist those facilities and communities in addressing economic viability, particularly in the low volume facilities that tend to be the case more often than not in rural versus urban parts of the state. I'm going to share with you plenty of data on health workforce shortages, looking at physicians, nurses, mental health professionals, and some other type of health professionals in rural areas. Always want to try to point out that while our focus is primarily on clinical positions, rural areas are also beset by problems attracting non-clinical staff as well, managers, billers and coders, and so forth. And I think I've abundantly documented the unique transportation challenges, and we'll discuss those a little bit. Then finally, since we're in session in Nevada, always thinking about the legislature and the fact that the rural communities and providers our office work with not only compete with urban areas for public resources, I would go one step further and say they also compete, frankly, for the attention of public policymakers in the state that, while attentive to rural issues, are preoccupied with a wide range of public policy issues in affecting urban areas of the state. Okay, so to jump into the data, if you will, I'm going to go over some, just a couple of slides on demographic trends and highlights that are contained in the data book. The first looks at just overall population growth, and Nevada for the better part of 2 decades was either first or second in terms of being the fastest growing state in the country. A lot of that was driven by population growth in urban areas of the state, particularly Clark County in the south. But we always like to point out that population change and growth was equally fast and important in understanding demands placed on rural providers, among other things, and increased over that 25-year period by nearly or over 70%. This slide kind of dissects some of that change, and my primary point in highlighting differences between rural counties and frontier counties represented by the blue bars, as well as a change in the state's 3 urban counties, is again, we saw net population growth over the last 25 years in 12 of the 14 rural and frontier counties. In some cases, very rapid growth, as was the case in Lyon and Nye counties, well above the state average. Something literally visible in any rural community you visit is not only increases in population, but increases in the patient or the resident population age 65 and over. Again, this diagram highlights the degree to which this was a rural as well as urban phenomenon over the last couple of decades, and the fact that you have the majority of rural and frontier counties that have experienced over 100% growth in this population. Enormous implications for the demand for healthcare and the ability of facilities, again, that we work with to attend to this growing segment of the population. Another demographic change highlighted in the data book is rather remarkable growth in the Hispanic population in the state of Nevada. That state average is obviously driven by what's taking place in Clark County and urban areas of the state, but again, note the blue bars and the fact that most counties in rural and frontier Nevada have seen anywhere from 100 to 400% growth in the segment of the population that claims Hispanic ancestry. And then kind of rounding out the discussion of demographic information contained in the data book is the growth of our veterans population. And something that I consider a distinctly rural phenomenon versus urban areas of the state is that percent of total county population who are vets. And most of the blue bars there exceed what's taking place in urban areas. And again, while most of, or the greatest proportion of vets reside in the state's 3 urban counties, when you look at the percent of population and then think about some of the unique health and healthcare needs of that population, we see a sizable segment of basically every rural and frontier county in the state. I'd like to stop there and just see if anyone has any questions and open it up before continuing on to health insurance coverage and that data. Okay, I will proceed then to share some of the information that we have on health insurance coverage. The most recent or available data that we have at our disposal on the percent of population under the age of 65, that is under the Medicare age eligibility. And this is a good story because in all 17 counties of the state of Nevada over the last 6 or 7 years, we've seen a drop. So When I showed this slide 3 or 4 years ago, we were looking at uninsured rates between about 18 and 25% for most counties in Nevada. Still, the fact is that most counties have at least 10 to 12% of their population who are uninsured, but progress in literally every county of the state. Now, part of that growth has, and particularly in rural areas of the state, has been the growth of that population, again, age 65 and over, and that's borne out by increasing enrollment in the Medicare program. But it's also been the case that we've seen growth in both private plans and those that have gained insurance coverage in our state in a pretty short period of time as a result of our state's participation in the Medicaid expansion. Some of the slides going forward include data on Nye County. I recently presented some information to a community group and to the hospital in Pahrump, which is undertaking a community needs assessment. So I'm going to share a little bit of that data, and not singling out Nye, but thought you'd be interested in, again, how rural counties compare to the state, and then in some cases, not information on Nye County. In this slide, my slide title is slightly incorrect. These are numbers of uninsured residents in the 3 regions highlighted in the slide: Nye County, all 14 rural and frontier counties in the state, and then Nevada at large. And what you see here is a good story by just about any measure, and that is a drop in the number of uninsured in both rural and urban parts of the county. When I presented this information in Pahrump a couple of weeks ago, I think there was surprise the degree to which, in a pretty short period of time, that community has seen their uninsured rates drop, in this case over 35% in a 6-year period. And again, it parallels what's taking place in Nevada as a whole, but one of the things that really stands out in that slide, again, is that the insurance coverage gains have been even greater in rural parts of the state versus urban areas in the state as a whole. Now, like all glasses that are half full, there is a potential kind of a half-empty element to that. Yes, I think most hospitals and clinics are happy to have more paying customers and residents with an insurance card in their back pocket, but a lot of that growth or gain has taken place in public health insurance coverage over the last 5 years. And again, this is the state's 14 rural and frontier counties. We've seen the Medicaid population grow by over 50% to about 51,000 individuals now covered on Medicaid, as compared to 33,000 in 2011. Likewise, we've seen about a 20% increase in the Medicare population. And then finally, we've highlighted data here on those who have gained coverage through the Medicare prescription drug program. And again, we point out kind of this good news, cautionary implications of this data, and that is, again, providers in rural areas that are fortunately seeing more insured patients, but oftentimes from public payers that pay below cost and well below commercial rates seen in those areas. Again, a little bit more data on Nye that I thought I would share with you. Looking at this slide from left to right, you see segments of the population, in this case of Nye County in the blue, or 14 rural and frontier counties in the red, and then Nevada as a whole. And the story here is that despite impressive gains in health insurance coverage as a result of the Affordable Care Act, we still see significant segments of the state's population and state's rural population that are uninsured. For the entire population as a whole, and again, going left to right, we see in the case of Nye, and I think this is similar across many rural counties, a little over 12% of the population is uninsured, but that for all rural counties, that percentage is 13%, and the states even being a little bit higher. Similar story when we divide up or look at segments of the population, whether it's kids under the age of 19, the entire population under 65 or not eligible for Medicare, and then those under 65 who are poor, in this case at or below household incomes at 138% of the federal poverty level. And another way of just simply stating this is, with respect to health insurance coverage, Nevada, including rural areas, have made progress over the last 5 or 6 years, but sizable segments of the population remain uninsured. I now want to turn to information collected on primarily from sources that we rely on that at the state level and the federal level on health behaviors and associated risk factors. This is a very rich part of the data book, and I'm going to only highlight a couple of principal drivers of, in this case, chronic disease, looking at obesity prevalence, tobacco use, and other risk factors. And kind of highlight what is taking place in Nevada and what might be unique to rural parts of the state. I was recently reviewing our state's county health, or our state's health rankings, publication from the United Health Foundation, and they always point out that obesity levels in Nevada as a whole put us in a favorable ranking. That is, when we compare ourselves to other states, we compare favorably, and I think that's only because the majority of states are simply have more of their population who are obese or overweight. And one of the cautionary things I want to point out is whether we look at the state level or in respect to this slide, the county level, what we are seeing almost uniformly across our state's 17 counties is a slow increase in obesity prevalence. If you looked at this same data a decade ago, the bars in every single county would reveal a lower percentage. So takeaway here is one of the principal drivers of chronic disease is obesity, and one of our biggest health and public health challenges is trying to stem that epidemic and that rise that we're seeing in all parts of the state. Now, kind of a counter trend is what we've seen in tobacco use, and this figures here look at percent of county populations county populations whose adults smoke, and unlike obesity, if you look at these bars 10 years ago, what we would have seen is a much higher prevalence rate for smoking and tobacco use. So there's a good story in that. I'm not showing trend data, but the evidence highlights decreases in tobacco use, particularly adult smoking, in most counties of the state. Nonetheless, if you just take a quick glance at that bar, pick your county other than Story County, and we're still seeing adult prevalence rates for smoking between 15 and 20%, and in a couple of counties at or above 20%. Here's a somewhat busy table, so bear with me here. I don't have aggregated data for rural and frontier counties of the state. I do have county level data. Did not want to put every county on going through these risk factors, but what you will see here is a pretty common story, and that is risk factors for chronic disease at the county level, represented in this case again by Nye County, and again just pulling from some recent data that we presented in FORUP, comparing that to overall Nevada rates, and then where we stand compared to the country as a whole. And kind of what you see across these risk factor categories, the first one being individuals self-reporting a diabetes diagnosis, obesity prevalence, the percent of adult population that are physically inactive, using tobacco or excessive alcohol consumption. Almost uniformly, rural rates higher than Nevada state rates, which are higher than US prevalence rates. Couple of exceptions there, most notably excessive alcohol consumption. That frankly comes as a little bit of a surprise, but Nevada rates being kind of on par with national levels. But again, comparatively high levels of behavioral risk factors to health in rural versus urban parts of the state versus US averages. Now I'm going to go through the next set of slides pretty quickly, and what we're looking at here is mortality rates. The first one will be mortality rates for all causes, and then I will look at some of the leading causes of death. Again, there is a good story here, not necessarily revealed in this information, but all-cause mortality rates have, at the state level, seen a decline, and we've seen a decline in most counties on this. But again, what you see is considerable variation across our counties. And the metric that we're using in this particular diagram is a rolling average of age-adjusted death rates rolled up to the most recent year that we had data available, and that was 2014. And again, a variation in the green bars, which are urban counties in the state, versus the blue bars represented, which highlight rural and frontier counties. Looking at leading causes of death, kind of what we find in a look at this mortality data is that for heart disease, the age-adjusted mortality rate for the entire state is 191 deaths per 100,000 population. Rates have declined over the last 5 years in half of the counties in the state, but nonetheless a fair amount of range among counties, from 121 deaths due to heart disease in Pershing County to 205 in Washoe County. Second leading cause of death in our state and the country for that matter is cancer or malignant neoplasms. The average rate for the state of Nevada is 162 deaths per year. And again, a good news story. We've seen rates decline for cancer mortality in 12 counties in Nevada, but considerable variation across Nevada's counties in, again, this key indicator. The rate in Lincoln County is 63 deaths per 100,000 population as compared to over 200 in Eureka County. Third leading cause of death is chronic lower respiratory disease. And again, a variation across the counties. Little suspicious of that figure for Esmeralda, and think that might be a function of low numbers. But again, on average, higher rates for lung disease in rural versus urban parts of the state. Likewise, typically higher mortality rates. Again, these are adjusted for age, so it's not simply a function of having older populations. We're seeing higher lung cancer mortality in rural versus urban parts of the state, and some pretty strikingly high rates for somewhat populous counties in rural regions such as Churchill and Nye. Here's another one of my busy slides that I presented in Nye. Again, I wasn't able to roll up mortality data for rural and frontier counties, but this is a very common story or theme that we see when we look at leading causes of death in rural communities in Nevada versus the state as a whole, which are driven by Clark County and urban residents, and then against U.S. metrics. And a very monotonous theme when we look at the 5 leading causes of death in the state, and that is rural rates higher, in some cases significantly higher, and in the case of heart disease, COPD, and lung cancer, rural rates higher than statewide rates, which are in turn higher than national rates. Okay, next section of the data book, and an important one. We collect a lot of information on the state's health workforce. Very important information for providers in the sense that a good deal of this information eventually funnels into data collected by our state's primary care office and reviewed by the Health Resources and Services Administration to determine what parts of the state and what communities are health professional shortage areas, which in turn affect reimbursement and loan forgiveness and other federally run programs. In the next set of maps and data, what we're highlighting are areas of the state which are shortage areas. In this case, the blue or blue shaded areas are federally designated shortage areas down to the level of the census tract. And the white or non-shaded areas are non-shortage areas. And this map, unfortunately, has not changed a great deal in the time I've been in this office. We've seen that most areas of rural and frontier Nevada are federally designated primary care health professional shortage areas. 10 of those 14 rural counties, the entire county is a single county health professional shortage areas. But we also see this in urban parts of the state. In other data we have available in our office and available online, we highlight what you can't really see there in the urban parts of those maps, and again, as segments or census tracts of those populations residing even in our urban counties that are designated shortage areas. Keeping on the theme and look at data regarding our physician and other primary care workforce, these are licensure counts that we tallied for the year 2016, the most current data that was at our disposal. And again, a very monotonous theme here, and that is whether you're looking at primary care physicians at the bottom there, or PAs or advanced practitioners of nursing, whether you're looking at licensed physicians as a whole or osteopathic physicians, considerably higher per capita rates in urban areas of the state as compared to rural and frontier counties in the state. Similar story with respect to mental health professions. Basically, all 14 of our state's rural and frontier counties are mental health professional shortage areas. That is to say, areas in which the number of psychiatrists, psychologists, and other mental health providers are below the level considered to be adequately staffed and available for residents of those counties. And this is just an issue that hasn't gone away. I think the state has taken some strides in addressing our state's mental health workforce issues, but plenty of challenges and work remains ahead of us. And again, these shortages were much more acute in rural parts of the state versus urban areas of the state. This is looking at a handful of key occupations in mental and behavioral health care, and with the exception of alcohol, drug, and gambling counselors, urban rates considerably higher than rural and frontier per capita rates. These are per number of health professionals per 100,000 population. The number for psychiatrists is striking, considering that close to 300,000 individuals reside in those rural and frontier counties. Final set of workforce metrics that we look at are dental health professional shortage areas. A little bit better story than what we saw in primary care, certainly better than what we've seen in mental health professional shortage areas. But again, a kind of an enduring issue faced by rural communities in that state. A little over half of our state's rural and frontier counties are federally designated dental health professional shortage areas, and these extend into urban areas of the state. And while we have seen some success in counties such as Churchill County, Humboldt County, and Eureka County in addressing those dental health professional shortages, all it takes is for one dentist in any of those counties to retire or cut back on hours, and we see the potential anyway for those counties slipping back into a dental shortage designation. Again, improvement, but a problem in many rural counties. There's those per capita numbers again. Now, while the number per 100,000 population for hygienists is kind of equal across the state, a pretty significant difference in per capita rates, higher in urban versus rural. Now, I think I'd like to acknowledge that we've made a considerable improvement. When I moved to the state 20 years ago, we were 50th in the country in our oral health workforce. And I think having a dental school makes a difference. Changes in licensure and reciprocity make a difference. And we have seen some progress there. I'm going to close out my discussion and hopefully leave some time for some questions or comments by taking a snapshot at the resources available in the state. Many of those who are on this ECHO clinic today reside in those areas, and good to see you. This is kind of our current assessment of both inpatient and outpatient clinics, some private, several public, in particular VA and tribal clinics and hospitals scattered across the state. Kind of what you see is a division of labor in our state with hospital services and hospital-based rural health clinics located in the more populous areas of rural areas of the state, and then medical care and services provided by FQHCs and community health centers in slightly less populated communities, such as Jackpot and Fort McDermott and other smaller communities. I want to close then by trying to tie some of this data to kind of an inventory of what I consider to be major rural health policy issues. As I go through this list, you will see our legislature really trying to wrestle with a majority of these issues. The degree to which they will be solved or addressed or remedied by our 2017 legislature remains to be seen, to put it mildly. But these are perennial issues that they grapple with, and that you see federal policymakers, including HRSA and other key health agencies, attempting to address. The financial barriers remain with us, and that's borne out by not only some of the insurance coverage data that I shared with you earlier, but what I consider to be equally important issue of underinsured. And that is individuals who may have a health insurance product or card in their back pocket, but are beset by considerable cost-sharing requirements associated with insurance. Tried to highlight the degree to which Nevada has a number of geographic barriers to accessing care. That is some pretty unique time and distance issues, but ones that are being addressed by telemedicine and by telehealth applications, including Project Echo. One of the issues that, key issue that the State Office of Rural Health and those we work with, such as Nevada Rural Hospital Partners and our state's Primary Care Association, is addressing the economic viability of what are largely low-volume facilities. Many of the hospitals that I work with may have one or two, if they're lucky, 3 inpatients, but still need to maintain staffing levels and the availability of diagnostic services and so forth. Again, perennial issues of viability, in part associated with low volume in those facilities. Also associated with aging physical plant and capital needs. That preceding hospital that I showed you from Mesquite is an exception to the rule, and that is a majority of our facilities deal with aging physical plant and capital needs that again compound their economic viability. Another related issue is the outmigration of patients from rural areas. Some rural residents traveling to Reno or Las Vegas or Salt Lake or Boise for services that are unavailable in their communities are in that, just a feature of healthcare in this state and in the rest of the country, but an issue of people migrating or leaving their communities for care that they could receive at their local rural hospital or clinic is one that, again, is perennial, and we attempt to assist them with that. On the horizon, if not already here, are issues associated with how we finance and support and make viable long-term care services. And I would say every community, rural community in this state. Rounding out the list, and again, in part revealed or illuminated with some of the data I've tried to share with you today, are abundant mental and behavioral health care needs, as well as barriers. An issue I didn't really address with the data, but I know that we're seeing more attention to from both state and federal policymakers are attempts to integrate our somewhat distinct and bifurcated primary care and behavioral health systems. A lot of effort and good work being done in that area. I've also highlighted chronic workforce shortages, shortages that are compounded in several communities with an aging physician workforce, and the retirement of health professionals as the economy has improved. I would be remiss if I didn't point out the important issue of emergency medical services and workforce and resource deficits that dog most rural communities in this state. Many of those EMS services are volunteer, or if not all volunteer in their nature, and it's made recruitment and retention more difficult. And again, long-standing rural issues that remain on the policy radar screen here in Nevada. Also want to point out something that the Nevada Office of Rural Health has given a lot of attention to in the last couple of years, is working with communities attempting to address largely underdeveloped public health services and local boards of health. Elko, Churchill County are exceptions to the rule of communities or commissioners that have not convened boards of health. Those two counties now have local boards of health comprised of their commissioners a local health officer and their local sheriff. And we've tried to aid in that development by helping them primarily with facilitation and data collection and dashboard development. But by and large, Nevada is striking in the degree to which public health services are underdeveloped and provided by state government as compared to the 3 urban counties in the state that have health districts and boards of health that meet on a monthly basis. And then finally is the ongoing or perennial issue of dollars and our state's budget issues, which appear certainly to be better than they were 4 or 5 years ago, but a state that has long-standing historic underinvestments in not only public health, but healthcare as well. That is a scene from Interstate 80 right outside of Battle Mountain in Lander County. I promise I take all my pictures when my car is stopped, but it's impossible not to be always amazed by the beauty of rural and frontier counties. I want to close by just highlighting some resources. Again, the data book is where a good deal of the information contained in this presentation was drawn from. Also want to point out other programs and projects overseen by the Office of Statewide Initiatives and the UNR School of Medicine. And if you would like information on any of these, please do not hesitate to contact me. Also want to point out that our office is very proud of our spiral-bound Rural and Frontier Health Data Book, and I'm happy to mail anybody on this call or meeting a hard copy of that, but we try to make everything that we've ever put our hands on data-wise available online, and we do so primarily through our Instant Atlas, which we've developed over the last couple of years. It allows you to query data, whether you're in Eureka County or Churchill County or Elko County, develop maps, comparisons with other rural counties, state averages, and in some cases, US averages. A wealth of information is available for you at that site. Last but not least, and I have left a little bit of time, is my contact information and how to reach me, where to find me, as well as, again, that link to the Office of Statewide Initiatives website, which will direct you, and you'll be able to find reports and data that I've mentioned throughout this presentation. With that, I'd like to open it up to questions. Troy, if anyone has any.
June Hunter has a question here.
Hi, June.
What were the biggest surprises in the data for this iteration of the data book?
Oh my gosh, that's a tough question. There's always surprises. I think the fact that I'm still pleased to see that the uninsured rate dropped, both numerically and as a percent of the entire population in every county. I knew and anecdotally knew what was taking place in urban counties of the state, but was pleased to see that, I guess, taking place in all corners of rural Nevada. Other questions?
Hi, John. This is Diane McGinnis.
Hi, Diane.
Hey, I have a question for you, and it's always perplexing me. If you're doing carve-outs in urban areas, how come we don't carve out Nye County?
What do you mean by that?
Well, because Nye County is showing a huge amount of providers that they're basically all around.
Yeah. Well, I wouldn't disagree with you. Now, one of the things I should point out that we're planning on doing with the community health needs assessment and I don't consider it a Pahrump or a Desert Valley needs assessment. It will be for Nye County, and I think we will be able to do that for Nye County. For example, all of the county level health workforce data that I shared, I have down to the level of zip code. So for that assessment, I will be able to talk about the number of providers, which are right now incredibly scarce in the northern part of that county, and Tonopah in particular, versus southern parts of the county. So we have that ability. Again, all of the data in the data book is largely aggregated at that county level. Another county in which it's important, Nye is not only important to do that, I think Elko County and Lyon County are two more examples of why it's important to do that. And we're happy to assist with drilling down to that level, Diane.
Thank you.
Yep.
I'm happy to help you with some of that data.
Okay. Well, I think where we can get help from communities is, frankly, vetting some of that information, because licensure counts are one thing. It's another as to whether that person who is still have an active license to practice medicine or nursing is even working or working full-time, or even providing care in that community where that license is mailed. We know a good number of providers practice in the county which they don't reside. So you can help us with that.
Hello.
Hello.
Hi.
You talked about more being insured. Do we know what percentage are underinsured? We've got quite a few folks out here that got those high deductible plans.
Yeah.
So for everyday stuff, they're relatively uninsured.
I don't, but I would like to get my hands on that information. I work with the insurance commissioner and their advisory, serve on their advisory council for network adequacy, and this comes up in every single meeting. And that is not only cost sharing and co-deductibles, but the degree to which provider networks pass the laugh test. And that is, it's one thing for an insurance company to claim an adequate network that often runs up against the experience I think you're talking about. Equally important issue, and we're trying to start looking at this by looking at Medicaid claims data, and that is the number of particularly individual providers that accept Medicare and Medicaid. That's another form of underinsurance in the state that's pretty striking. And we're taking a close look at that right now in Elko County, where, again, you've seen insurance coverage improve over the last 5 or 6 years, but a lot of that has been county residents who've gained Medicaid and Medicare coverage that can't get in to see a provider if they're not willing to accept that form of insurance.
Exactly. Thank you for your work you're doing.
Yep. Any other questions?
Any other questions?
I see a question from John Wilson regarding mental health services and underserved in that part of the county. Was there something more specific? All I would say is yes. That's borne out by our data as well. Well, again, if there's no additional questions, you have my contact information, and I would love to send anyone a hard copy of the data book. It's a great reference, if I say so myself, and we're happy to share that with you anytime. But also check out the reports and data that are available on the Office of Statewide Initiatives website. Thank you.
Thanks, everyone.